Good morning, everyone. Well, OCT, optical coherence biometry, is a non-contact, non-invasive means of investigating retinal diseases, which has revolutionized ocular disease management. And it's like an optical biopsy, which gives us cross-sectional images of the retina. OCT has been evolving over the years, and now we have this very high-resolution OCT. The OCTs are still evolving and different layers are still being identified. So it's a very dynamic process. Every day you hear new terminologies, new layers which are being identified. So this will go on for some years. There are many different OCT machines in the market, but most of them have similar scan protocols, and most of the spectral domain machines give you similar pictures. However, one point that I'd like to point out is that please do not compare the thickness of the retina in all the machines, because they all follow different protocol, means to measure the retinal thickness. So one machine would give you this thickness, the other would give you this thickness. So you cannot compare the thickness between two machines. These are the different layers in a color coded. The hyperreflective layer on top is the nerve fiber layer, and this red layer is the retinal pigment epithelium. Most of the times in the spectral domain OCT, we do not like to see the colored picture. It's the black and white image which gives us a more clearer, well-defined image. So I'll explain the layers on this. If you start from here, from the outer retina, this is the choroid. This is the retinal pigment epithelium. This is again, there is another layer which you see above it. I'll be talking about this later. For now, it's this the retinal pigment epithelium. This is the inner segment, outer segment junction that we all hear of, also called the photoreceptor integrity line. Above this is this lighter band. This is the external limiting membrane. Above this dark band, this is the nuclear layer. This is a nuclear layer, and this dark band is the nuclear layer. This is the outer nuclear layer. This is the inner nuclear layer. This is the outer plexiform layer. This is the inner plexiform layer, and this is the ganglion cell layer. Innermost is the nerve fiber layer. So these are the layers. I'll be talking about them in detail subsequently. If you correlate these with the retinal structures, so you see here, these are the RPE interdigitations, the photoreceptors, and this whole area is actually the area where the photoreceptors are present, and this is where the inner segment and the outer segment of the photoreceptors, the junction of the inner segment and the outer segment. Also, on the OCT scan, the nerve fiber layer is thickest near the optic nerve, and it's almost absent temporal to the fovea. So this would be your nasal side, and this would be your temporal side. Just by looking at the scan, you can say whether this is the nasal and this is the temporal side. When you're looking at an OCT, first of all, it's important to determine the overall scan quality. So if you've got a scan like this, you can definitely better it by positioning the patient, repeating your scan. So this is the scan quality that you should aim for. Of course, artifacts are there, as the previous speaker pointed out, motion artifacts, eye closure artifacts. If a patient has a dry eye, you can ask him to blink to get a better picture. Also, superficial structures always cast a shadow over the underlying tissue. So if there's something in the vitreous, you'll see a dark zone behind it. This is called shadowing, just like the ultrasound. So the structures here will be missing. There's no pathology here as such. Also, these bands on the OCT, you'll see regular bands like this on the spectral OCT. These are nothing but the blood vessels which are casting their shadows here. All these blood vessels here. So you do not get confused with this. When you're looking at an image, first of all, try to identify the two major interfaces. That's the vitreoretinal interface and the RPE choroid interface. So that gives you a baseline working idea from where to begin. After that, look at this overall scan profile. Try to see the contour of the detachment of the retina. Is it detached? Is the RPE detached? Is the RPE elevated? So here you see the RPE is elevated here, it's not flat. So just get a rough idea. You'll get a very quick picture just by looking at it. This is a pigment epithelial detachment. Here you see this is the pigment epithelial detachment, and also the retina is elevated. So there's also retinal detachment. This is the case of CSR, and also pigment epithelial detachment. Because the pigment epithelial is raised, here you see the Bruch's membrane also, interestingly, in this picture, which is not usually seen. And then you see the retinal contour, this edema in the retina. So this is a case of branch retinal vein occlusion. After that, what we're most interested in is to evaluate the foveal profile. So the normal fovea has a slight depression in the center. This is how the normal fovea looks like. This is the vitreous, a complete PVD. So this is the fovea. The outer segments are thinner and longest. So the outer segment in the foveal area. So this band here is thickest, and it appears to form a peak. This is the normal foveal peak here. So don't think that this is a pathology, it's a very normal structure. Also you see here the outer nuclear layer is the thickest in the foveal area. So then look at the foveal profile. Is it normal? Is it normal like the one you saw, or is it deformed? That could be deformed by various things like an epiretinal membrane going over the fovea. There's another epiretinal membrane causing a lamellar hole and a full thickness hole. Also, it's important to identify the foveal cut. Many a times you may get your OCT scan, but it's not through the foveal center. If the patient has not fixated enough, if the patient has poor vision, he's not able to fixate, you just take an image and it's not through the foveal area. So do make sure that you look for this foveal contour in all your images. Try to see that you've gone through the center of the fovea. You can ask the patient to fixate, or you can move your scan line up and down. After that, carry out a structural assessment. Look at all these structures one by one. See the posterior vitreous phase, the vitreoretinal interface, neurosensory retinal layers, inner segment, outer segment junction, RPE, and the choroid now with the newer machines. Also identify additional structures which are not part of the retina. These structures could be preretinal, epiretinal, intraretinal, or subretinal. So this, like I showed before, is a PVD. This is a vitreomacular traction. An epiretinal membrane here causing a lamellar hole. So this is where you start from, the vitreoretinal interface, the first layer that you see. Then you see the retinal layers as such. This case of a cystoid macular edema, you can see that there are these cystoid spaces present in the nuclear layer, in the outer nuclear layer, also in the inner nuclear layer and the ganglion cell layer. Also here you see that the photoreceptor line is separated from the retinal pigment epithelium. There's some fluid here. So these are all intraretinal changes. These are some areas of hard exudates, and you see they are casting a shadow. So these are the subtle things that you should look for. At the foveal area, the spectral domain OCT delineates three highly reflective lines. The two I've already talked to you about, the external limiting membrane and the photoreceptor integrity line. The third is, now that we are hearing a lot about it, is the COST, or the cone outer segment tips. This is a third line here. In most of the scans, you may not be able to see it also, especially if you have an edema or an overlying pathology, it may not be very clear. So these lines, all these three lines, serve as a hallmark for the evaluation of photoreceptor function. The photoreceptor integrity line should be continuous throughout the scan, and it correlates very well with visual acuity. Here's a case of an operated macular hole. You see the macular hole is sealed, but this line, the photoreceptor integrity line, is ending here, and it's ending here. So this patient did not have a post-operative good visual acuity. Again, this is a case of vitreomacular traction. You see but that the photoreceptor integrity line is ending here. Also it's ending here. It's not continuous in the foveal area. So again, this patient will not have a good visual acuity, so you can prognosticate. The COST line that I mentioned is in association with the ISOS junction and the external limiting membrane. Now this is a useful prognosticating factor after ERM and macular hole surgeries. This, I said, is the COST line. This was a patient who underwent macular hole surgery. So you see the COST line is here. This COST line generally after macular hole surgery can appear even after 6 months. So this starts to form later. Once you have a fully formed COST line and the PIL line and the external limiting membrane, such a patient would have good vision. After that, after you've assessed these layers, then look at the retinal pigment epithelium and the structures under the retinal pigment epithelium, that's the subretinal epithelium layers. So again, like I said, this is a pigment epithelial detachment. This line that you see here, don't get confused, this is just the Bruch's membrane. Whenever the pigment epithelial is detached, sometimes you can see the Bruch's membrane here. Also, the choroid is not very visible in this area of the PED. There's a little bit of shadowing because the melanin pigments get concentrated here in the PED, so you might get a little shadowing here. But all the other layers are almost continuous. This is a case of CNVM with a lot of fibrosis and scarring. And these here, you cannot really identify the layers. This is a retinal pigment epithelium. And these are tubulations in the photoreceptor layers. This is again another term that's now being talked about a lot in advanced cases of CNVM. These are tubulations, tubular-like structures in advanced cases. So when you're talking of the RPE, you can talk about all these terms: irregularity, fragmentation, rupture, interruption, depression, elevation, thinning and thickening is how you describe it. So I'll just take an OCT and take you through how to interpret it in a systemic manner. First, you identify the RPE here. Then you examine the RPE. In this case, this is a case of RAP, or retinal angiomatosis proliferation. Here you see that the RPE is continuous. There's one single elevation here, which is a pigment epithelial detachment. You see its wavy line. There is no interruption in the RPE, and there's no thickening or thinning of the RPE. Then examine posterior to the RPE. So here you see that there are some shadows here in the shadowing over here in the RPE areas. Otherwise, the reflectivity is all right. After that, you look anterior to the, examine anterior to the retinal pigment epithelium. So what all do you see in this case? You see hyperreflective areas in the inner layers. These are the inner layers. You see these hyperreflective areas. You see these large hyperreflective precipitates. These are hard exudates. Then you see intraretinal cysts here in two layers. You see that the retinal thickness is increased, and you see also some subretinal fluid here. And most important, you see that there is an interruption of the IS-OS junction, also of the COS line that I talked, and the IS-OS junction. So again, this patient would not have a very good visual acuity. Just to end my talk, sometimes the OCT picture can confound you. You may get a bizarre picture like this, but if you keep your cool and analyze all the way, you'll get the answers. So you see here, this is just a mere shadowing. There's something here that is causing a shadowing of all the posterior layers, and this was a hemorrhage, pre-retinal hemorrhage in the macular area. So enhanced depth imaging OCTs can also now give you the thickness. The choroid can be very well imaged with these newer machines, especially, and this is important in cases of posterior uveitis and cases of CSR. 3D rendering is there in almost all the machines now. It's a very important tool, more so to show to the patients. And this is how the output would look like. So I'll not go into the details of that, but one thing that I'd like to point out is that whenever you have, when you're analyzing an OCT, do look at all the images, whatever all the images that have been taken, because you might, if you just see one image, you might miss significant data. And I think that's all.
Thank you, Dr. Tinku.